Okay, let's unpack this. You know that feeling, right? You're on shift in the ER and suddenly your nursing radar just pings.
Hmm.
Maybe it's, a patient with a totally blank stare or an unexpected jerk of a limb, or maybe it's that full, unmistakable convulsion that just, well, stops you in your tracks.
Yeah.
In those moments, your mind races through a million possibilities, right? And while lots of things could be going on, epilepsy is definitely a major contender. And it's way more varied than maybe we first realize. Understanding those nuances is just so vital for us in the ER.
It absolutely is. And what's really fascinating, I think, is how much your keen observation, right there in those high-stakes, super fast-paced moments, how much that actually contributes to effective care and, importantly, accurate diagnosis down the line.
Yeah.
So this deep dive today, it's really all about highlighting the why behind what you're actually seeing on the floor. We want to pull out those crucial nuggets of knowledge, give you maybe a bit of a shortcut to being well-informed, help you navigate the complexity of seizures with hopefully more clarity and confidence.
Yeah, exactly.
So one mission is to cover, well, everything from recognizing the subtle seizure types to the really critical management steps, and of course what happens after the seizure, all tailored as like peer-to-peer education for you guys working in the ER.
Okay, so when we talk about that initial radar ping and you're thinking, okay, maybe this is a seizure, your first thought, obviously beyond immediate safety, is often what exactly is happening here?
Hmm.
And that brings us right to the core definition, doesn't it? Epilepsy. At its heart, epilepsy means unprovoked, recurrent seizures. It's like a sudden, unpredictable electrical misfire in the brain that just keeps happening.
Exactly. That keeps happening part is absolutely key. It's not just a one-off event. It's this pattern, this recurring pattern of electrical storms. And recognizing where that storm starts in the brain, is it localized? Is it hitting both sides right away? That's what determines the seizure type you're seeing.
Ah, okay.
And your ability right then and there to differentiate those patterns, that's crucial. It guides the initial care. It informs the whole diagnostic team.
So let's break those patterns down then, starting with the focal onset seizures. These can be kind of sneaky, right? They start in just one specific bit of the brain.
Hmm.
The first type is called a focal aware seizure. Now, this one I think often surprises people because it doesn't fit that classic seizure picture.
Yeah.
Can you kind of walk us through what that conscious misfire looks like for the patient?
Yeah, absolutely. So imagine someone is fully awake, totally aware, and they can actually describe what's happening to them. Maybe it's a strange smell or taste, that weird deja vu feeling, or just like an isolated jerking in one arm. Their brain is misfiring, electrically speaking. But they're there. They can tell you about it afterwards. So the critical takeaway for us as nurses is you never dismiss a patient describing these seemingly minor things while they're totally alert.
Right.
This is a seizure, and it's our cue to, dig a bit deeper.
That's such a vital distinction, especially when things are moving so fast. And speaking of quick assessments, let's shift to the other big category seizures that hit both sides of the brain right from the start, the generalized onset ones. But hang on, before we do that, there's another focal type that can be easily misidentified too, right?
That's right, yeah, the focal impaired awareness seizure. Now here, consciousness is affected. So the patient might look like they're awake, but they aren't truly aware of what's going on around them.
Okay.
You might see them staring blankly or doing these things called automatisms, repetitive, kind of non-purposeful movements, like lip smacking, fiddling with their clothes, just fidgeting over and over.
Okay. I've seen that.
Yeah, and crucially, they won't remember the event afterwards.
Yeah.
And here's a really important caution for us as nurses. Try not to jump straight to assuming it's drugs or alcohol.
Good point.
This is an electrical misfire in a specific brain area messing with their awareness, not necessarily just altered mental status from substances. Your objective notes documenting those automatisms. That's key.
That distinction alone, yeah, that could prevent a lot of missteps in the ER. Okay, now let's dive into those generalized onset seizures affecting both sides of the brain right from the get-go. One type that can be super easy to miss, especially in kids, is the absent seizure, what used to be called petit mal.
Right, these are your classic staring spells.
Yeah.
You see them a lot in children. It's almost like someone hits a pause button on their consciousness. They might just abruptly stop whatever they're doing, stare blankly for maybe 5-10 seconds, and then just resume, like nothing happened. Completely unaware they lost that little bit of time. So for an ER nurse, especially with pediatric patients, this can look so much like daydreaming, or maybe even an attention issue. The key differentiator is how sudden it starts and stops, and that complete lack of awareness during the event itself.
Gotcha. And then, of course, we have the one everyone recognizes, the tonic-clonic seizure, grand mal. This is what most people picture, I think. How does that usually play out?
Yeah, it's pretty dramatic. It typically starts with the tonic phase. The
Yeah.
body stiffens right up. Sometimes there's a cry as air gets forced out of the lungs, and boom, immediate loss of consciousness.
Okay.
Then that's quickly followed by the clonic phase, which is characterized by that rhythmic jerking movement of the arms and legs. And during these, it's not uncommon to see things like tongue biting or incontinence. Basically, the brain just loses control over those vital functions for a bit. To put it in a context we see all the time, think about something like AFib in the heart.
Ah, yeah. Good analogy.
Right. You've got electrical impulses just overwhelming that part of the organ, firing like crazy. Well, the same sort of uncontrolled electrical storm happens for a short time in the brain, leading to these really dramatic physical signs.
That analogy really nails the internal chaos. Okay, another generalized type, and this one has big safety implications for us in the ER, is the atonic seizure, the drop attacks.
Yeah, these are sudden, just abrupt loss of muscle tone leads to an instant collapse. These patients are at a really high risk of getting injured from the fall.
Oh, definitely.
So for us as nurses, this means these patients, they should always be on seizure precautions. And we need to keep re-educating them about using their call bells, understanding their fall risks, because even a simple drop can cause a nasty head injury or fractures.
Absolutely. And finally, just to round out the generalized types, myoclonic seizures, what do those look like?
These are much briefer. They're characterized by sudden kind of shock-like jerks or twitches, usually very short, and the person typically stays conscious the whole time. So you can really see the huge spectrum, right? From these subtle internal feelings to full-body convulsions. Knowing these different presentations is critical for assessment, obviously, but also brings us to another layer of complexity that's super important for us in the ER. Understanding the mimics, specifically psychogenic non-epileptic seizures, or PNES.
Ah, right, PNES. This raises a really important question, doesn't it? How do we, at bedside, try to tell the difference between a true neurological event and something with a psychological root? PNES, sometimes still called pseudo-seizures, look so much like epileptic seizures, but like the name says, they come from psychological causes, not that abnormal brain electricity.
Exactly. And while, getting a definitive diagnosis needs specialized stuff like a video EEG, your sharp bedside observations are absolutely vital for the diagnostic team. Your objective notes, documenting the specific features you see, as truly being an advocate for these patients. It helps guide the team to the right diagnosis without unnecessary delays.
That's where our assessment skills really have to shine. So, what are some key differentiators we should be looking out for? Thinking about movements, epileptic seizures often have that rhythmic, synchronized jerking.
Right.
But with PNES, you might see more irregular, asynchronous thrashing, maybe. Or even that side-to-side head shaking or prominent pelvic thrusting, which isn't really typical for epileptic seizures.
That's exactly right. And another clue can be the eyes. In PNES, they're often kept tightly closed, whereas in many epileptic seizures, the eyes might be open or maybe rolled back.
Okay, eyes closed tightly. That's a good one to remember.
Yeah, and pay close attention to any sounds.
Yeah.
During a PNES event, you might actually hear coherent speech or crying. That's less common during an epileptic seizure where vocalizations are usually more guttural or maybe that initial ickle cry. Also, the duration and the recovery period offer huge clues. PNES events might last way longer than a typical seizure, sometimes minutes, even hours occasionally. But then they often end with this surprisingly rapid recovery. They just kind of snap out of it, totally bypassing that long, groggy, post-ictal phase you usually see after a big convulsive seizure.
Ah, that rapid return to baseline.
That's a major red flag for PNES. Yeah.
Okay. Knowing those subtle but significant differences, that can really impact patient care, prevent unnecessary interventions, maybe even harmful ones. Right, let's pivot now to what happens once you've identified a seizure and the critical clock and managing it acutely. What's our immediate priority here?
Well, the good news is many seizures, thankfully, they just stop on their own within a couple of minutes. No specific medical intervention needed.
Okay.
So your first nursing actions really need to focus on ensuring safety, meticulous observation, and this is critical, keeping track of the duration. Every second counts.
Timing it.
Exactly.
Yeah.
And this brings us straight to that crucial 5-minute rule and the concept of status epilepticus.
That 5-minute mark, yeah, it's burned into every ER nurse's brain, I think.
Oh.
What exactly defines status epilepticus, and why is that 5 minutes so critical?
So status epilepticus is defined as continuous generalized convulsive seizure activity that goes on for 5 minutes or longer.
Hmm.
Or it could be multiple seizures happening back to back without the patient returning to their baseline level of consciousness in between.
Okay.
That 5-minute mark is a widely accepted threshold for intervention. Why? Because seizures lasting that long are much, much less likely to just stop on their own. And they significantly increase the risks of neurological injury, plus systemic problems like prolonged hypoxia.
Right. Big risks.
Huge risk. So there's a very real, very urgent need for medical intervention at this point. Typically, the first line is benzodiazepines, an appropriate dose, say 2 milligrams of IV Atrovon. The goal is to halt the activity and raise that seizure threshold.
So for you, the nurse, in that moment, it's like controlled chaos, right? Focus completely on safety and getting ready for rapid intervention. When you're faced with an active seizure, especially one getting close to or past that 5-minute mark, safety is number one. What are the absolute non-negotiables we need to remember in that immediate chaos?
Okay, first things first. Ease them gently to the floor if they aren't already down. Cushion their head, prevent that head trauma. Quickly clear the area around them. Get rid of any hard or sharp objects. Don't forget a quick check of the neck, any ligature risk like necklaces or ties. And if you can, get them turned onto their side. That helps prevent aspiration because vomiting is a big risk, and their protective reflexes are gone during the seizure.
Side lying position, crucial.
Absolutely.
Yeah.
And then remember the critical don't evers. Never, ever try to forcibly restrain their movements. You risk breaking bones or causing skin injuries. And never, ever try to put anything into their mouth. You could break teeth or, worse, cause them to aspirate.
Right. No bite blocks, no fingers. Got it. Safety first, always. And once you've got the patient secure, what's our next immediate focus, even if maybe they've just gotten medication?
Right. Even post-medication, immediate airway management and oxygenation are still paramount. Keep a really close eye on their breathing, their skin color. Hypoxia is common, and you've got the assessment skills to spot it without needing the pulse ox right away.
True.
If they look cyanotic or if their SATs do drop, be ready to apply oxygen with just a simple mask.
Yeah.
And having suction equipment ready to go, absolutely critical. Keep that airway clear, especially as they might have secretions or vomit during the postictal phase.
Section ready, okay.
And remember to document everything accurately. Times, interventions, the specifics of the seizure itself, what kind of movements, how they progressed, any sounds, changes in consciousness. That documentation is absolute gold later on for diagnosis.
Okay, now, scenario. You've hit that 5-minute mark, you've given the initial benzo, maybe Etivon, and it just doesn't seem to be stopping. Or maybe the patient's having multiple seizures, boom, 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 without getting back to baseline in between. Now you're truly in status epilepticus territory.
Yeah, that's a true
A real emergency. Needs early treatment to prevent that irreversible brain damage. So beyond the standard benzos, what else might these patients need? What's next?
It really is a race against the clock at this point. These patients often need intubation to secure their airway. They might need larger doses of benzodiazepines or even second-line anticonvulsants.
Okay.
And for those of you working in triage, remember if you don't have IV access right away, medications can often be given IM, intranasally, IN, buccally, or even rectally.
Good options to have.
Definitely. But while you're pushing these potent meds, you must be diligently monitoring for side effects. Things like respiratory depression, hypotension, excessive sedation. You have to be ready to support their ventilation if needed. Stopping the seizure is critical, yes, but ensuring they're adequately oxygenated and perfused is just as vital.
Absolutely. Okay, so once that active seizure finally subsides, thank goodness your focus shifts again. Now you're navigating a postictal state, which can be really challenging. These patients are typically just wiped out, right? Profoundly sleepy, confused, disoriented, maybe complaining of bad headaches, muscle soreness.
Exactly. Exhausted is the word.
Yeah.
So your nursing actions here, it's about methodically reorienting them, ideally in a quiet, low-stimulus environment to minimize agitation. Keep up with those neurochecks as ordered you're assessing their recovery, looking for any new deficits, and critically, do a careful assessment for any injuries they might have sustained during the seizure. Check for tongue lacerations, any signs of head trauma from a fall. Address those injuries.
Right. Okay, this brings us to a really interesting point about diagnostics and potential pitfalls, especially if it's a new patient or someone without a known history. Seizure activity, particularly those big tonic-clonic ones, can temporarily mess with lab results, can't they?
Oh, absolutely.
This is a key aha moment, I think, for anyone reading a chart later. Like, a bystander might look at the labs and think sepsis, But knowing the context of a recent seizure completely changes how you interpret things.
Exactly. You might see their lactic acid levels skyrocket post-seizure, simply from all that intense muscle activity.
Hmm.
Or you might see a mildly elevated white blood cell count of leukocytosis just as a stress response.
Yeah.
And if we connect this to the bigger picture, recognizing these transient changes, it helps prevent misdiagnosis, it stops unnecessary interventions, it ensures you don't start treating for an infection that isn't there, saving the patient from maybe unnecessary tests or antibiotics.
Right. If there's no other clear reason, you can often chalk those values up to the seizure itself. Okay, another useful biomarker. If you can manage to get a blood draw within maybe 10-20 minutes after the event, is prolactin.
Prolactin?
Apparently, it can be notably elevated after generalized or complex focal seizures. That can be helpful sometimes in differentiating them from PNES, right?
That's correct. It's another piece of the puzzle. And don't forget about CK creatine kinase. That can also rise from the muscle exertion, maybe for a day or two after a significant seizure.
Okay.
And you do have to be mindful, especially if there was trauma, like a fall, or if the person was lying in one position for a long time afterwards. There's a higher risk for muscle breakdown, potentially leading to rhabdomyolysis.
Rhabdo. Yeah, always got to keep that in mind. Okay, so beyond these temporary lab changes, we always need to be thinking about other potential root causes for an unexpected seizure, right?
Always, absolutely. We're talking about things like electrolyte imbalances, sodium, calcium, magnesium, hypoglycemia. So always get an AccuCheck once the patient is stable,
Definitely.
or signs of an underlying infection that might have triggered the whole event. Once the patient is stable, the next steps in the workup usually involve CT imaging, looking for structural issues.
Yeah.
And if they get admitted, neurology will almost certainly want an EEG.
Okay. So boiling it all down, what does this mean for you in the ER? Your actions right there in the immediate aftermath, they're all about stopping the seizure activity and keeping the patient safe.
Hmm.
But your critical thinking doesn't stop there. It continues as you look for those root causes, as you interpret the labs and context. There isn't, a whole lot more you can acutely accomplish beyond stopping the activity and ensuring safety.
Precisely. While the acute intervention focuses on stopping the seizure and immediate safety, the whole long-term management picture is about seizure control, preventing future events. And your precise observations, your detailed documentation from that ER encounter, that is foundational for their future journey. It enables the neurologist to accurately diagnose and manage these patients effectively long-term.
And that really brings us full circle, doesn't it? This deep dive, we've covered a lot the sheer variety of epilepsy, the critical role we play as ER nurses in recognition, immediate management, post-seizure care. It's amazing to think this is a condition that's been recognized since Hippocrates, over 2,300 years ago?
Yeah, incredible, isn't it? Shows you how long humanity has been grappling with understanding these brain events.
It really does.
And the evolution of our understanding means that now you have the knowledge to properly treat and document for your patients with really incredible precision. This deep dive, I hope, shows that while a seizure can feel like this completely uncontrollable event, the nurse's controlled chaos, your sharp observation, that's truly what brings control back. Not just for the patient, but for the whole diagnostic and treatment process.
That's a great way to put it.
And maybe it raises an important question for you to think about. In a high-stakes place like the ER, how does your precise documentation of a seizure today actually influence that patient's long-term care trajectory, maybe years down the line? Something to mull over.
Definitely something to think about. Well, thanks for joining us on this deep dive. We really hope you feel even more prepared now to handle those critical moments and to be a strong advocate for your patients. Until next time, keep digging, keep learning, and keep making a difference out there.